Hello everyone and welcome to our module on pulmonary circulation. So in this video, we're going to talk about the pulmonary circulation of blood, meaning how blood flows through the lungs. And the first thing to know about the pulmonary circulation is that it's a relatively low pressure system. So you may know a normal blood pressure in your arterial system systemically is about 120/80. A normal blood pressure in the pulmonary artery, however, is much lower. It's about 24/12. And because the blood pressure is lower in the pulmonary circulation, the walls of the blood vessels are much thinner. So the walls of the pulmonary artery are relatively thin compared to the walls of the aorta or systemic arteries. There's relatively little smooth muscle. The walls are thin and compliant, meaning they're stretchy, so there's low resistance to flow, and the blood vessels are very distensible, meaning they are compliant. The amount of oxygen in the pulmonary circulation, in other words, the blood oxygen content, has an important effect on pulmonary blood flow. So in the systemic circulation outside of the lungs, when there's a low level of oxygen in the blood, in other words, a low PaO2, this leads to vasodilation in many tissue beds. And the idea is that many tissue beds recognize the low oxygen content and they vasodilate to raise the amount of blood flow so that they continue to get enough oxygen. In the pulmonary circulation, the opposite happens. When the oxygen level gets low, when there's a low PaO2, this leads to vasoconstriction of pulmonary vessels. This will decrease blood flow through areas of the lungs. This is called hypoxic vasoconstriction, and the idea is when there's a low level of oxygen in blood flowing through the lungs want to shunt that blood away because they presume it's a poorly ventilated area, and this will drive more blood flow to well-ventilated areas. And so we've evolved this to try and prevent blood from flowing to areas of the lungs that have poor ventilation. And this is important in adults to keep blood flowing to well-ventilated areas, but it's very important as well in the fetal circulation. So in utero, there's a relatively low oxygen content of the fetal blood, and this constricts pulmonary vessels. And that's one of the reasons that blood doesn't flow through the lungs very much in the fetus. Instead, it bypasses the lungs through structures like the ductus arteriosus. At birth, however, when the arteries receive lots of oxygen, then they begin to dilate. And that's why when the baby is born and it starts to breathe air and have ventilation of the lungs, much more blood flow begins flowing through the lungs. And I talk about fetal circulation in detail in other videos. So just to make this very clear, if you were to graph the oxygen content of blood, in other words, the PaO2 versus the amount of blood flow, when the oxygen content is low in the systemic system, which is the green line here, you have a lot of blood flow, but in the lungs you have very little. And then as the PaO2, the oxygen content goes up, you get relatively less flow in the systemic circulation, but you get more flow in the lungs. Okay, now we're going to talk about gas exchange, meaning the process by which blood flows through the lungs and picks up oxygen and releases carbon dioxide. And in order to do this, I've drawn a cartoon on the slide here. This is an alveolus. This is a pulmonary capillary. We have venous blood entering the capillary here. It's leaving and it goes to the arterial side of the body, and we have arterial blood over here. So the first thing to know is that the air we inspire from the atmosphere goes through our nose and our mouth. It becomes humidified. It goes through the trachea, and it enters the lungs with a makeup that looks like what's shown here. Partial pressure of oxygen is about 150, and you can think of partial pressure as simply the concentration of oxygen in the gas, and the amount of CO2 is essentially zero. But once that air reaches our alveoli, things start to change because the bloodstream picks up oxygen and releases carbon dioxide. So the PaO2, which was 150 in inspired air, falls to 100 inside the alveoli, and the pCO2, which was 0, rises to 40. So hopefully this makes sense to you. This is just happening from oxygen being picked up by blood and carbon dioxide released. On the blood flow side, venous blood enters the pulmonary capillaries with an oxygen content of about 40 millimeters of mercury and a partial pressure of carbon dioxide of about 46. The blood then flows past the alveoli and things change. So oxygen gets picked up and the PaO2 in the arterial blood rises to about 90. And the PaCO2, which was 46, falls to about 40. And what's happening here is the concentrations are equilibrating between the alveoli and the arterial blood. So the CO2 is becoming the same in the arterial blood as we've got in the alveoli. The PaO2 is also becoming the same, but the reason there's a difference between 100 and 90 here is because we have some mixing of blood from veins like the Thebesian and bronchial veins. These are veins in the lungs that don't allow blood to flow past alveoli. So the blood in these structures right here does not get oxygenated, and it mixes with the blood flow coming out of pulmonary capillaries. And so that's why the concentration of oxygen in your arterial blood is always a little bit lower than what you've got in the alveoli. It's because of mixing of deoxygenated blood that didn't flow past alveoli from these structures I've listed here, the Thebesian and bronchial veins. So if you think about what we just went through on the last slide, we have venous blood, which is deoxygenated, getting pumped or delivered to the lungs. This is the perfusion of the lungs by blood. Then we have diffusion of gas in and out of the bloodstream such that the blood and the alveoli become equilibrated. And so if you understand these steps here, then you can understand that we can classify gases by whatever is the limiting factor for gas transfer. Some gases are limited by the perfusion of blood flow to the lungs, and some are limited by the gas diffusion. So gases that are perfusion limited, the blood flow, the perfusion is what limits how much gas can be exchanged. And if there's more blood flow, you get more uptake of gas. I'll talk more about this in just a second. On the other hand, gases that are diffusion limited, it's not the blood flow that determines how much gas exchange, it's how much diffusion of gas there is into and out of the alveoli and the blood. So to make this more clear, let's consider the example of nitrous oxide. Nitrous oxide is a gas that we don't normally inhale, but it can be administered to research subjects. It's also sometimes used as an anesthetic. But in pulmonary physiology, it's the classic example of a perfusion-limited gas. So let's imagine that we have an alveolus here, and the concentration of nitrous oxide in the alveolus is 100. That 100 is this P sub A I've shown here. It's the alveolar concentration of nitrous oxide. Now let's imagine we have blood come in and enter a pulmonary capillary, and we graph the length along the capillary as the x-axis. And on the y-axis, we graph the partial pressure of nitrous oxide. Well, you can see here that as blood moves along the capillary, the concentration of nitrous oxide quickly rises, and by about halfway along the capillary, it's reached the maximum value it can attain. It can never get higher than this value of 100 inside the alveolus. Once it reaches that level, it's equilibrated and it can't pick up any more nitrous oxide. So you can see that blood fully equilibrates with the alveoli by about halfway, and we have completely saturated the blood with nitrous oxide. And so this is how a perfusion-limited gas behaves. Basically, the blood becomes fully saturated by some point along the capillary, and the only way to get more blood flow into the bloodstream is to have more perfusion. In other words, to keep pushing more blood past the alveoli. And now I've cleared away my ink so we can talk about carbon monoxide, which is the pulmonary physiology classic example of a diffusion-limited gas. So if you were graphing carbon monoxide, it would look like this green line here, which you can see is very different from the blue line. And what's happening here is carbon monoxide is never able to reach the concentration in the alveoli at any point along the pulmonary capillary. That's because the uptake of carbon monoxide in the blood is being limited by diffusion, not perfusion, and therefore we never reach this maximum value like we do for nitrous oxide. So shown on this slide are examples of a classic perfusion-limited gas, nitrous oxide, and a diffusion-limited gas, carbon monoxide, and how they behave when you flow blood past the pulmonary alveoli. Okay, so carbon monoxide and nitrous oxide are not gases we normally inhale. How do the gases we normally inhale, like oxygen, behave? Well, oxygen behaves like what I've shown on the slide here. So oxygen enters the pulmonary capillaries with a partial pressure in the blood of about 40. We talked about this a few slides ago. And in a healthy lung, quickly the oxygen concentration reaches 100, which is the maximum value. That's the concentration of oxygen in the alveoli, and therefore oxygen is perfusion limited under normal circumstances in a healthy lung. If, however, the lungs develop fibrosis and fibrous tissue is deposited in the lungs, that becomes a barrier to diffusion. And so oxygen uptake can become diffusion limited in disease states where you have some barrier to the uptake of the gas. And so fibrosis is the classic example of a disease process that converts oxygen from perfusion-limited uptake into diffusion-limited uptake. Let's talk about what happens when a person ascends to high altitude. So we talked earlier about how inside the alveoli, the partial pressure of oxygen is about 100. Well, that's what it is at sea level. But if a person ascends to a very high level, it can get lower, as low as 60. So in this case, when blood flows past the alveoli, the PaO2 can never rise to above 60. So the patient can develop hypoxemia at high altitude, but that doesn't mean that anything's changed about gas exchange. Oxygen remains perfusion limited. It's just that its maximum value now is 60 instead of 100. And so on your step exams, they may ask you about what happens to gas exchange at high altitude. You should be aware that it remains perfusion limited, even though the patient can develop hypoxemia because of the lower partial pressure of oxygen at high altitude. And then on this slide, I've shown the behavior of carbon dioxide. It is also perfusion limited under normal circumstances. The graph of how its concentration changes, however, looks different because we don't take up carbon dioxide, we give it off into the lungs. So remember that blood enters the pulmonary capillaries with a pCO2 of around 44 or 45 or so, and then it drops down to about 40 as it moves past the alveoli along the pulmonary capillaries. But once again, it equilibrates fully by the time it gets to the end of the capillary. You can see that here, and that means that it is a perfusion-limited gas. In clinical medicine, there's a diagnostic test we use in certain pulmonary disorders to measure the gas uptake of the lungs, and that test is called the DLCO. DLCO stands for the diffusing capacity of lungs for carbon monoxide, and it's a diagnostic test that measures the ability of the lungs to transfer gas. The way the test is done is the patient inhales a small amount of carbon monoxide. You may know that carbon monoxide is dangerous, but the small amount used in this test is believed to be safe. And the reason we use carbon monoxide is because, as we just discussed a few slides ago, its uptake by the lungs is diffusion limited. So the amount that gets taken up is proportional to the diffusion capacity of the lungs. So the patient inhales a small amount of carbon monoxide, and when they exhale, the carbon monoxide level is measured. Normal is based on the predicted for the patient's physical characteristics. So normal is about 75 to 140% of predicted. Severe disease is less than 40% predicted. And so for the step 1 exam, you don't need to know a lot about how this test is used clinically, but you do want to understand that the reason it uses carbon monoxide is because that gas is diffusion limited. And therefore, when you see a problem with carbon monoxide uptake, you know there is a problem with gas diffusion, not a problem with gas perfusion. So there are a number of pathologic disorders that lead to a low DLCO, and I've shown some of them on this slide. And in order to understand why these disorders lead to a low DLCO, we have to look at this equation right here, which is Fick's equation for gas exchange. So this equation tells you the volume of gas that will be exchanged based on these factors listed right here. So let's imagine that P1 right here represents the partial pressure of oxygen inside an alveoli, which we already talked about is 100. And P2 represents the partial pressure of oxygen in the blood, and we've already talked about how venous blood entering the lungs has an O2 partial pressure of about 40. So the first thing that's going to determine how much gas diffuses is the difference between these two numbers right here. There has to be a difference to drive diffusion. But diffusion also depends on the area for gas uptake and the thickness of the barrier through which the gas must diffuse. And then also this factor here, D, which relates to the individual gas. There's a different D for oxygen and carbon dioxide and so forth. And so you're not going to need to calculate something by this equation. You just need to understand the principles behind it. So for example, in emphysema, patients have a low DLCO, meaning there's an impairment to the diffusion of gas. That's because there's destruction of alveoli and there's decreased surface area. So there's a low surface area, and what Fick's equation tells us is that will lead to a low volume of gas that can diffuse. In patients who have fibrosis or pulmonary edema, you get an increased thickness of the barrier through which the gas has to diffuse. And so that's what leads to a decrease in the amount of gas that can diffuse. And so these are examples here of disorders associated with a low DLCO, meaning an impairment to the diffusion of gas. But the reasons for the impairment to diffusion of gas are different depending on the disorder, and they all tie back to Fick's equation right here. Okay, the next topic we're going to discuss is pulmonary vascular resistance, which refers to the resistance to blood flow through the lungs. And in order to understand this concept, you have to appreciate that there are two important vessel types found in the lungs. There are the capillaries that surround the alveoli. These are called the alveolar vessels. And then there are so-called extra-alveolar vessels, which are arteries and veins, not the capillaries surrounding the alveoli. And so when your lung volume increases, when you inspire air, this crushes the alveolar vessels to some degree. It increases the resistance to blood flow through those structures. But in contrast, the extra-alveolar vessels actually get pulled open when you inspire air, so their resistance to flow goes down. So the total resistance of blood flow through the whole pulmonary system, in other words, the pulmonary vascular resistance, depends on the combination of these two effects and which one is dominant. And so in the pulmonary physiology videos, I talk about the concept of the FRC, which is the functional residual capacity. It's the volume of air inside our lungs at the end of a normal quiet breath. And it turns out that this is the point in the respiratory cycle where you have the minimum pulmonary vascular resistance. And this is just sort of a pulmonary physiology classic thing that you need to know. So when you're breathing quietly, in other words, not forced inhalation or forced expiration, at the end of exhalation, right before you inhale, that's where your lungs are at the FRC, and that is when the pulmonary vascular resistance is at its lowest point right here. You can actually calculate a number for the pulmonary vascular resistance, although it's very unlikely you'll need to do this on your step exams. But this can be done from the flow equation, which is shown here. And I talk about the flow equation a lot in the videos on cardiology. And the flow equation says that the pressure difference you need to drive blood flow through a system is equal to the volumetric flow rate you want to achieve times the resistance to flow. So let's imagine we have a couple of lungs here, and we want to drive some fluid to flow into the lungs and out of the lungs. Well, the pressure difference we need to have, in other words, the difference between the pressure here before the lungs and the pressure here after the lungs, that's going to be equal to how much blood we want to flow through the lungs times the resistance to flow. And so for the lungs as a system, the pressure difference is equal to the pressure in the pulmonary artery minus the pressure in the left atrium. So the mean pressure in the pulmonary artery is usually somewhere around like 20 or so, give or take. And the mean pressure in the left atrium is usually somewhere around 10. So it's this pressure difference going from a high pressure to a low pressure, a difference of 10, that drives blood flow through the lungs. The volumetric flow rate of blood flow through the lungs is the cardiac output, and the resistance to flow is the pulmonary vascular resistance. And so if we rearrange this equation here, we get this equation, which tells us all the variables that fit into the pulmonary vascular resistance. It's related to that pressure difference across the lungs divided by the cardiac output. But even though you can calculate pulmonary vascular resistance from that equation on the last slide, what we usually think about when we're thinking about pulmonary vascular resistance is the pressure in the pulmonary artery. Because when this gets high, that's called pulmonary hypertension, and that's a serious condition that can lead to right heart failure and even death. So by rearranging that equation on the last slide, I've shown you here the equation for the pressure in the pulmonary artery that would determine whether that pressure is normal or abnormal. And so the pressure in the pulmonary artery is equal to the cardiac output times the pulmonary vascular resistance plus the left atrial pressure. And so this equation shows you the two main ways that patients develop a high pulmonary artery pressure, in other words, pulmonary hypertension. One way is if the left atrial pressure gets high. This is the most common cause of pulmonary hypertension, and it's referred to as pulmonary venous hypertension because the pressure is high in the pulmonary veins that feed into the left atrium. And so any kind of left heart problem like heart failure or valvular disease can lead to high left atrial pressure, and that can cause pulmonary hypertension. And that's the most common way patients develop this problem. But the other way that pulmonary hypertension can develop is if you have a high pulmonary vascular resistance. This is referred to as pulmonary arterial hypertension because you have high pressure in the pulmonary arteries, high resistance to flow, and that's what's driving the high pulmonary artery pressure. And there are primary and secondary forms of pulmonary arterial hypertension. And I talk about all these things in a separate video on pulmonary hypertension. But for our purposes here, discussing pulmonary physiology and pulmonary circulation, I just want to point out to you how the pressure in the pulmonary arteries is determined by all these variables here. And that concludes our module on pulmonary circulation.